Hi, everyone, and welcome to today's Research America Alliance member web meeting. As always, thank you all for your partnership and participation in our alliance. A couple of quick housekeeping items, which you all know by heart by now. Since we are using Zoom webinar, all audience members are on mute. You can use the electronic raise hand feature at the end of the discussion, and we can unmute your line if you have a verbal question, or you can type your question into the Q&A box at any time, and we'll take questions in just a little bit. For those of you that don't know me, my name is Sarah Chang, and I am the Director of Advocacy Programs here at Research America. And today we're going to talk about the critical intersection between the pandemic and mental health, including PTSD and depression. I'm joined by Dr. Alan Peterson. Dr. Peterson is the Krus Endowed Chair in Psychiatry at the University of Texas Health Science Center at San Antonio. He's the board-certified clinical health psychologist, professor and chief of the Division of Behavioral Medicine in the Department of Psychiatry and the School of Medicine. He also serves as the Deputy Department of Psychiatry Chair for Military Collaborations, the Associate Director of Research for the Military Health Institute, the Director of the Strong Star Consortium, and the Director of the Consortium to Alleviate PTSD. Dr. Peterson retired from the U.S. Air Force in 2005 after 21 years of active duty, including service as the chair of the Department of Psychology and the director of the American Psychological Association accredited Clinical Health Psychology Postdoctoral Fellowship Program at Wilford Hall Medical Center. Alan, thank you so much for joining us today. We thought it was very timely and important to hear from you as we are all in the middle of a holiday season for many of us. Your research into PTSD can have many applications for the military and beyond. Tell us about how your work can be relevant today as we find ourselves facing this pandemic, especially over the holidays.
Sure. So thanks for inviting me today. It's very exciting to be here. As was just mentioned, I'm retired military and trained as a clinical psychologist. My graduate school mentor was actually a well-known researcher named Nathan Azrin, and he was considered, still is considered, he's deceased now, one of the fathers of behavior therapy. His graduate school professor was B.F. Skinner, which may be someone that a name that you recognize. So I was trained to do research early on in my career and always have been interested in doing research, even though I'm primarily worked as a clinician. I was active duty on 9/11. I had been on active duty for 17 years. I had never deployed a single time. And before 9/11 was over, I was on an aircraft flying to McGuire Air Force Base, Fort Dix in New Jersey to set up an expeditionary medical squadron to support the casualties of the Twin Towers. It was a rude awakening for me. After about 3 days, we didn't have many more casualties that were there, so I was asked to lead a team to Dover Air Force Base, which is where they have the Armed Forces Mortuary, and my team helped support about 700 individuals who were deployed there to do human remains identification. So every day there were tractor trailers and helicopters of body bags, primarily from the Pentagon, bringing human remains. And these were people that were not necessarily pathologists. Their job was to help identify the human remains of those that were deceased. We did that for about 3 weeks. I was told you need to get back to San Antonio, came back to San Antonio, and 3 days later I was deployed to Operation Enduring Freedom. So my life kind of turned upside down on 9/11. A couple of years later, I was asked to deploy to Iraq to help set up an Air Force theater hospital. And that's where I started to see a lot of the combat PTSD cases coming in. We had really no science to direct what we needed to do then. And so that really got me thinking on what the needs of the nation were. And so when I came back from that deployment, I decided to go ahead and retire, moved across town here to the medical school, and I've been here since then. And over the past 12 years, I've set up a nationwide research alliance, if you will, called Strong Star and the Consortium to Alleviate PTSD, and it includes about 150 or so investigators nationwide, all of us working together to try to address post-traumatic stress disorder and related conditions in active duty military and veterans.
Thank you. Another aspect of your work is is resilience. Can you talk a little bit about the connection between resilience and what we need today?
Sure, sure. So if you look at use the military as an example, about 15% or so that come back from a deployment are at risk for post-traumatic stress disorder. And that's been a lot of my research emphasis. The flip side of that, which we don't think about very often, is the other 85%. The other 85% really are incredibly resilient, because most everybody that's deployed, there will be trauma exposure, sometimes dozens, if not hundreds of trauma exposures. And yet those individuals are coming back without PTSD. So for the military, it's primarily training. If you can train someone for known things that they're likely to expect, no matter how difficult or stressful they are, if you can train individuals for those, they normally do quite well with that. The things that trip people up are things that are just totally unexpected, that you really couldn't anticipate. And if you think about what's happened over the past 9 months or so with COVID-19, that was one of those things that you wouldn't really, hardly anyone thought about or expected. Interestingly, with my last military deployment, I started studying deployed military medical personnel to look at what is the impact of being in a war zone and treating these real severe war casualties, and what's risk and resiliency related to for them. It was interesting that a few years after that, actually in 2013, I was invited to present at the Continental Divide pandemic conference, pandemic behavioral health conference. And in 2013, they basically asked me to give a presentation on what do you think the medical impact would be, or the impact on medical personnel would be, if there was a pandemic flu. And I kind of thought, oh, whatever. But as I'm looking back on that, I was like, wow, that was many years ago. And yet there were some individuals that were trying to prepare for what would the impact be of a pandemic flu, which is basically very similar to what we're focused on now. So we're doing work on resiliency. Compared to other areas, there's been much less research on resilience. We have a study that's going on right now with military special forces looking at resilience, but there's a lot more we need to learn about the resilience area.
That's fascinating. I'm trying to figure out, there's two questions I'm interested in, but the first one I'll go with is, in resilience, what are your thoughts on COVID-19 and what's happening right now and the impact on children? Do you have any research in the space on how this might be different in children versus adults?
In most cases, believe it or not, in most cases, children are incredibly resilient, and many times they're actually more resilient than adults are. Again, this is something that's totally new, brand new, and so the science behind exactly what the impact is on and who needs help and who may not need help, there's still very little data right now. What is interesting is that the single strongest predictor of who naturally recovers from some type of trauma exposure is social support. So if you think about social support, and for kids, that would be your parents, your family, your siblings, your friends. So if you take social support kind of broadly described, that social connectedness, the social support that's there, no matter how difficult the stressor or how difficult the trauma is, that's the factor that's most likely to be related to natural recovery. And obviously, with COVID-19, there's limits in the social support that's there, and a lot of that ends up being virtual support now. And we were just talking a few minutes ago before we started about how children are adapting to that seemingly quite well to get support from friends and family through these virtual means. But trying to maintain the social support and the isolation piece, that's the part that's a big risk factor, are those individuals that really are isolated. And to some extent, almost all of us have been forced to have a level of isolation just because of the limitations of COVID-19.
How does the mental health impact of COVID-19 pandemic kind of compare to other traumatic incidents? Is there enough data out there yet?
There's not much. Again, the studies that I've done with military medical personnel who've deployed, those are some of the best studies that have been done so far. And for that population, it's about 5% or so. It doesn't sound like many, but it's about 5% or so that are likely to develop post-traumatic stress disorder after deploying and working with a lot of the trauma patients that are there. Once again, it's a large percentage of people that actually do quite well and are quite resilient. But if you look at 5% of medical personnel, and at any one point at our location, we had about 300 individuals. So every 4 to 6 months, if there's 15 medical personnel, physicians and nurses and others that are coming back that have post-traumatic stress disorder, it really has a major impact on your organization. For COVID right now, the individuals we're actually most concerned about are those that actually have had COVID, have been in the ICU, have been on a ventilator, that have had basically a near-death experience. Those are the individuals that are most at risk for developing COVID. Those personnel that are working on COVID units and whatnot, there's lots of stress, and there's some risk, obviously, of PTSD for them, but they're actually much more at risk for anxiety and depression difficulties than for PTSD. So that's a piece I think that's a little bit different than that. And then if you look at our community as a whole, it's more depression and anxiety that's likely to occur from our observations of what are going on in our families and our neighborhoods and our communities related to COVID-19. But the risk of PTSD from that is actually very, very low.
I want to touch on that a little bit more. Can you talk about some of the signs or symptoms and differences between those at risk for the PTSD versus depression and anxiety? That's interesting.
Sure. So for PTSD, there is exposure to an extremely traumatic event that's either life-threatening to yourself or someone else. There's extreme images that are there, and if you think about the war zone, it's those that are first responders after there's an improvised explosive device that's gone off, where there's lots of killed, lots of mutilating injuries, that type of thing. So for PTSD, it's nightmares, it's re-experiencing symptoms, or having images or having physical reactions. It's like a stress reaction that occurs when there's no real danger. So that's kind of an example of what happens with post-traumatic stress disorder. There's a lot of avoidance, so people will avoid thinking about a trauma, any kind of trauma reminders. They will stop. They will try not to think about it or avoid situations. So there is some isolation with PTSD, and actually a common comorbidity of PTSD is actually depression. And we think that is primarily a result of the avoidance piece that takes place, because people are avoiding many types of things. And so if you look at the depression piece with that, I think we're all familiar with depression. What's interesting with depression, one of the most effective treatments actually for depression that's been developed through really good science over the past several decades, it's a treatment called behavioral activation, which seems kind of strange. So there are a lot of cognitive behavioral therapies. There's some medications that can be helpful, but one of the most effective treatments is called behavioral activation, which basically is helping depressed individuals to get more engaged in their life, to do things, to do stuff. And the more individuals will do those things, their cognitions will change, their affect will change. They will start to recover from depression by being actively involved in activities. And if you think about COVID-19, it's been just the opposite of that, right? It's behavioral deactivation. Most of us have had to stop many of our behaviors. The things we used to do for enjoyment, for pleasure, many of those things have been taken away, and we've been very, very isolated, which is why there's big risks for depression and for anxiety as the two most common types of symptoms or even disorders that people may have related to the COVID-19.
What do you, when you are concerned that a friend or loved one might be experiencing PTSD or depression or anxiety, any mental health concerns, what are your recommendations?
Again, I'm trained as a scientist, so my recommendation is to seek out an evidence-based intervention. And there are many evidence-based interventions for post-traumatic stress disorder, for anxiety, for depression. I'm a clinical psychologist, and I'll be one of the first to admit our field can be a bit flaky at times. And there's many individuals that will deliver treatments in which there's really not much evidence that things are likely to be effective. And the PTSD consortium that I've established, that's really been our focus over the past 12 years. We've now done about 67 different projects, believe it or not. I sometimes use the example of cancer, right? Yeah, some of the best science has been done with cancer, and the most effective treatments are with cancer. That's because there's been so many clinical trials that have been done. And every time one of those is done, we learn some things. They're not always successes, but we build better and better treatments over time. For PTSD and depression and anxiety, we're just barely scratching the surface on that over time. But it's really important to try to seek out an evidence-based intervention. And you can do searches and whatnot that'll help you determine what those are. And just to give an example with PTSD, there's many organizations, there are many well-intended individuals that really want to help service members and veterans with programs. And so there's many things that have been stood up. You could take veterans on a whitewater rafting, go on a retreat. There's service animals that have been developed. There's many programs like that are developed, and people get very confused because they think they're actually treatments for PTSD, whereas those are not actually treatments for PTSD. Service dogs can be helpful in many different ways, but a service dog for post-traumatic stress disorder is not treating PTSD any more than a service dog for someone who is visually impaired is treating their vision or helping them improve their vision. It can maintain stability, but it's not going to treat it. PTSD is absolutely curable. It can be treated into remission. In fact, there's a much greater likelihood that an individual with PTSD can be treated into remission than most cancer patients can. But they need to get an evidence-based interventions, and we're not perfect. We don't have treatments that cure everybody, if you will, but it absolutely is it can be treated very effectively.
This is great. I have many more questions and I can keep going, but I want to open it up for for some audience Q&A now.
Sure.
Terry, do we have any questions?
Oh, yes, absolutely. And just to remind folks, you can add your questions through the Q&A and we'll try to get to as many as we can. For starters, let's see here. We've got a couple of different questions coming in. First of all, you mentioned just the importance of research on this. What are the biggest research gaps still that you're finding?
It's only about focus specifically on PTSD. We are effectively treating about 50% of the population. So we're doing well. And if you look across the board at all of the mental health disorders that exist, that's about where we're at with effective treatments. Is 40 to 50% of people will be treated really effectively. And again, if you look at cancer as an example, there's some types of cancers that have a very high cure rate these days. There's many others that's not the case, and you sometimes have to go through 1, 2, 3 different forms of treatment. If you think about cancer, though, I think that's normally the case. What is the treatment for cancer? Well, it could be radiation, it could be surgery, it could be medications, could be some combination. It could be a combination done in a particular order. And if something doesn't work, it's not that likely that people say, "Well, I tried that. I need to cope with my cancer and just accept the fact that I have cancer the rest of my life." And occasionally people do that when they've tried everything and there's not much hope that's left. But that usually is a last resort. Whereas mental health conditions, oftentimes people will try one thing, it may not work real well, and they assume that, okay, there's nothing else that we can do. I just have to live with it. And so I would encourage people, keep going back and seeking out additional care, because there's many treatments that are available, and it's hard to know how to match which treatments work best for which patients in which order. And again, there's a variety of treatments that are available. So persevere with that, because you can be helped with a variety of mental health conditions.
Great, thank you so much. Another question that's come in, someone who deals with incarcerated individuals, many of whom enter with PTSD. Are there any thoughts about the way in which incarceration exacerbates PTSD and what might be done for this population?
whether it's individuals who are incarcerated, homeless individuals. There's many populations that are just vulnerable to be assaulted, for example, and that's a high risk condition for high risk event for post-traumatic stress disorder. So even within those that are incarcerated, there are treatments that are effective. The one big limitation is part of the treatment of PTSD is to get individuals back involved in their community, get them involved in activities. And obviously for an incarcerated individual, there's going to be limits to that. And it's not until they may be released, if they reach that point where they'll be able to test themselves in some of those areas. So that's a big concern about the incarcerated is they are limited in what their activities can be. And so they can't expose themselves to some situations that they may normally be avoiding because they perceive them as being dangerous based on the particular event that may have occurred.
Great. Another question that's come in, again, coming back a little bit to the research gaps. Do you run into this sort of N of one issue in mental health where it's hard sometimes to generalize across individuals experiencing such a complexity of emotional and or physical symptoms?
I think I understand the question. So again, my graduate school professor, trained me, to develop and evaluate new treatments. And so I am very common doing N of one studies, if you will, because humans are so complex. And whenever I'm seeing a patient that has some complex things that are going on, and I'll look at the literature, and if there's not much literature that's there, we can do an N of one study ourselves. We'll try some things out. Let's see if this works. I've got 3 options here. We can try this, this, or this. And we will go through an N of one study with an individual patient, if you will. And then sometimes that results in us having a signal that's there. We realize there may be some hope in that. And that leads to the next largest study, And way back in time, the work that I did early on in my research career was with Tourette's disorder. And some of the initial studies were with 1, 2, 3 patients. And it's kind of a long story to tell you the whole story with that. But the work I did in graduate school to develop a non-pharmacological behavioral treatment for Tourette's disorder, here we are 35 years later, and this behavioral non-medication treatment for a neurological disorder, the treatment we developed called Comprehensive Behavioral Intervention for Tics, or CBITS, it is now the first line recommended treatment for Tourette's disorder in all of the international clinical practice guidelines. So starting with N of one, oftentimes is where you start, and then if you can persevere with that, you can sometimes eventually develop an effective treatment for a particular condition.
That's great to think that, one patient can lead us to a treatment that can then support others. That's fantastic. I've gotten a question specifically about CTE, brain injuries. Have you seen any particularly interesting developments in that area?
Sure. So just not specifically CTE, I'll talk about traumatic brain injury. So there's mild, moderate, severe traumatic brain injury, which is much more common. Mild would normally be called a concussion. And we're trying to use the word concussion for mild traumatic brain injury because I think we all understand what a concussion is. And I think most of us feel like with a concussion, people are likely to recover from a concussion. More of a moderate or a severe brain injury has many more long-term consequences of that. A big challenge right now is there's really no definitive evidence-based treatments for concussion, if you will, other than taking a time out, resting, letting your brain rest for a number of days, allowing some natural healing to take place. But beyond that, there's now been about 30 or so randomized clinical trials looking at the treatment of mild traumatic brain injury, and there's really not a good signal that's there. So we don't have much to offer with that. The chronic traumatic encephalopathy piece that occurs from the repeated brain injuries that occur over time, that gets even more complicated, if you will. So it's much more common for someone to have a concussion. Right now, it is letting your brain rest. The other thing to keep in mind is certainly for military personnel, the comorbidity of a concussion and other disorders like post-traumatic stress disorder are very high. The most common reason for a mild TBI for a deployed individual is exposure to a blast injury, for example, on the same device that can cause a brain injury or a concussion is also often related to post-traumatic stress disorder, because people are injured, they're killed, there's really bad injuries that occur with that. So the comorbidity piece of a traumatic brain injury with PTSD and substance use disorders and chronic pain and even suicide, there's lots of comorbidities. So it's quite rare that you have an individual with just one condition, if you will. It's much more common that there's comorbidities that exist. And just to get back to the question about gaps, that's one of the gaps, is how do you treat individuals that may have what we sometimes call polymorbidity, right? Where there's several conditions that are there, one of which may seem to be primary, but may be difficult to treat that primary condition because of the 2, 3, or 4 other polymorbidities that might exist as well.
Great. And here's another interesting question that's come in. You mentioned before the importance of social support in combating PTSD, and yet there's been some debate and discussion around the term social distancing during the pandemic. Some public health leaders have suggested we use the term physical distancing instead. Do you have any thoughts on that?
Absolutely. I totally agree. You want physical distancing. You want physical distancing, right? You don't want if you take that for what it means, the social distancing, it's 6 feet. 6 feet is the physical piece. Our best understanding right now is that the primary way that the COVID is spread is through air particles, if you will. So it's the physical distance piece. Socially, we want to try to stay as socially connected as we can, and you can maintain social connectedness, even if you're 20 feet apart, or even if you're doing it virtually or whatnot. So we want to do everything we can to maintain the social connectedness. So I agree that physical distancing is a much better term for that than social distancing.
Great. And we have time for just a few more, I think. One question that came up, we all know there are challenges with recruiting participants in any kind of studies, but are there unique challenges in recruiting individuals with PTSD to participate in research?
Absolutely. Certainly within the military, there's a big stigma of seeking out mental health care. And it's not just the military. It's like, even in civilian settings, there's a big stigma of seeking out mental health care. And so that's a big piece that's there that we're always trying to overcome. If you look at medical personnel, they are some of the last ones to come in for mental health care because of the added stigma of seeking out mental health care, maybe within your same healthcare system, if you will. So the stigma piece is a big challenge that we try to get around. The way I primarily focused on that is if we can develop the most effective treatments possible, so we can give people hope that you can come in, receive 8 sessions of a particular intervention, if you will, and maybe you've recovered and you don't have to come in anymore. That's a real benefit. With many of our studies, one of the things we've realized is that telehealth, sort of like we're doing now, you can deliver very effective mental health treatment through telehealth, and it's almost exactly equivalent to what you're like to get face-to-face in the office. And I actually was working on a manuscript this morning, which we actually started before COVID even hit, where it's a PTSD treatment. We're comparing face-to-face in a provider's office to telehealth from the provider's office to the patient's home. And the third arm actually was in-home treatment in the patient's home. And so we're just analyzing the results there. And one of the things I became aware of this morning was there's a double advantage, really, of the telehealth treatment. Not only is it as effective as face-to-face treatment, but for the other 2 arms of our study, if a patient has to travel into a doctor's office for care, the amount of time commitment is almost double that, because we're estimating 30 minutes commute to the office, maybe an hour treatment session, 30 minutes back. So anything you're doing, it is double the time frame. And with the in-home, where we sent our providers to the patient's home, it was just the opposite, where it's twice as much time for the provider. So the telehealth, we're realizing, wow, this really is a good approach for many individuals. And actually, it's a big time saver for either the providers or the patients, because either one of them does not have to commute for that. And the outcomes, at least for individual therapy, when it gets to group therapy and couples, it gets a little more complicated. But so far, most of what we found out through telehealth treatment, it's about as effective as in-person care.
Wow, that's amazing. One of those things that we say, there are some things that because of the COVID, maybe we won't be done with after the pandemic is over, that we're just going to stick with.
Right.
One other question that I did want to get to, one of the big sources of anxiety and depression that have come about because of the pandemic is for folks who are dealing with loss of earnings or their business or their home. Are there any particular recommendations for people dealing with that kind of situational challenge to get support?
Yeah, those are challenges that we've dealt with in the mental health area for many reasons, many years. There's people that experience that right now, but just more of them. Another treatment for depression, it seems kind of strange to think that this would be a treatment for depression, but one treatment for depression that's also shown to be very helpful is called problem-solving therapy. And basically, it is helping people to solve life problems. And right now, some of the complications you're just describing, there's no easy answer to that. But if someone has lost their job, how do they be creative? How do they problem solve? How do they figure out what else can I do to earn an income if that's possible? How do you resolve whatever that problem might be? And by learning skills to do that, people can recover from depression. And I would suggest that it's similar for the COVID. We need to be very clever right now, all right? And basically what I'm saying is one of the ways to help your anxiety and depression is not to just stay in your home and avoiding any kind of activities that are there. I'm saying you need to get out, you need to do things, you need to enjoy life while still following the guidelines that are there to not get yourself exposed. So it's not like an easy answer of how you do that, but trying to be clever, being creative, trying to problem solve. That I think is part of the solution for these many challenges that people are experiencing.
Well, great. Sarah, I'll hand it back to you. I'll just add, though, that we've had lots of questions that simply say, Dr. Peterson, thank you. Thank you for the work that you're doing. And thank you for your service for our veterans and for our service members. We really appreciate your time.
Sure.
Thank you, Terry. I couldn't have said it better. I do want to sort of wrap up with one final question. What's next on your research plate, and how can we, those that are watching today, Research America, are there ways that we can be helpful?
So I think a big challenge right now, and we didn't have a chance to talk too much about resiliency, but trying to understand more about resiliency. And I think the vaccine is a good example for this. So if a way to get over COVID-19 or be protected is to have immunity. So if you actually have developed COVID-19, you've been affected, then you may have immunity, so that may be helpful. Or hopefully soon we'll have a vaccine so that helps protect individuals as well. For stress, the stress of life, there's no vaccine for that right now. So how do you develop those immunities? Is you actually are affected by the condition, and that is life. So when things are difficult, when there's challenges, when you fail, when there's heartbreak, when all of those things occur, those are things that help develop resiliency over time. So having hardship, experiencing all the things we've experienced with COVID, big picture, it may not be as bad of a thing for those of us that come out the other side of things, in that if we can learn from this, it will hopefully make us and our families and our community even more resilient moving forward, so that we can deal with whatever else may come in the future that we can't really anticipate right now. So resiliency is a real challenge moving forward, and we need more help trying to figure out how do we help our communities, our families, our nation be more resilient.
Well, that sounds like quite the call to action, and we definitely we are here we appreciate all that you do, and thank you for your time today. We do have a few other questions, so I will try and get those to you, and we can't thank you enough. So thank you, Dr. Peterson.
You're welcome.
For everyone else online, we do have, want to remind you that we have one more Alliance member meeting coming up next Monday, December 7th. We're going to hear from Dr. John Lorsch, the director for the National Institute on General Medical Sciences. So thank you all again for joining us today. And I know that you enjoyed it just as much as we did. So thank you again and have a good rest of your day.